let me mention it's a great pleasure to have Mark in our series. He's gone through the hero's journey. You know, you are in a place, you travel, you do big things, and then you come back, and then he's back to talk to us about it. And we are very happy that you're here. And with Nina, she was a faculty here, as you've heard before. She was hired at the same time that I was hired, and we were good friends, and we've kept in touch. And I'm so glad that you guys can help us and give a presentation. So in few words, what we have, Mark began his career as a research assistant in the Department of Psychology here. And he completed his senior mentorship as a data analyst at Roswell Park. And we, as you all know, we have now a partnership with them, and Heather graduated from there as well. So he's been more than 20 years, has a career involved in healthcare, data, and public policy. So he's currently runs the health evaluations and management consulting practice in Northern Virginia. He previously held senior roles at 3 Fortune 200 companies: Humana, CVS Health, and Coventry. On the government side, Mark served in payment policy and data management roles at the Center for Medicare and Medicaid Services. And he was also a senior policy advisor to members of the Congress and their staff. He has a master's degree in health policy and administration from the University of Illinois, and completed the executive analytics program at Texas A&M University and the business of healthcare graduate program at Johns Hopkins University. He currently serves as the vice chair of the Advocacy Council of the American Health Information Management Association. Please.
Well, thanks for inviting me.
Yes, a pleasure.
Okay, so tonight what we're going to talk about is the opportunities in the healthcare field, why the healthcare field is dominated by data, and why even organizations that are data-focused organizations but not in healthcare end up in healthcare because of the business opportunities. On this cover slide, we have a building. It's on one end of one road in Baltimore called Security Boulevard. On Security Boulevard, half of the federal budget of the United States is spent between the Social Security Administration, and this building is 7500 Security Boulevard, or the headquarters of the Centers for Medicare and Medicaid Services that runs the Medicare program. So about $1.4 trillion is spent out of that building every year. And all of that spending is driven by claims processing and other data. We're going to talk about that more in a bit. I'm not going to spend a lot of time on this slide because Joaquin already did a great introduction. What I will say is I sort of fell into this. When I was at Buff State, I was in the Department of Psychology. I thought I was going to be a clinical psychologist. I was working as a research assistant in that department. That's where I got my training in data, more from a research perspective, focusing on survey research. But to be frank, I needed beer money. And Roswell Park had a paid internship. So I went to Roswell Park instead of some of the other internship opportunities. And there I got an opportunity to play with data in a hospital environment and work with physicians, work with nurses, work with people that don't understand data at all, but using data to solve problems in an environment where it had the ultimate meaning. You're trying to save people from a deadly disease. And I enjoyed that so much, I started to go down in that direction. The rest of my career has been mostly split between the federal government, a little bit of state government stuff, and then some very large Fortune 100 companies, in the case of CVS Health and Humana. And I'm going to talk more throughout this presentation about experiences in those environments. So again, why does this matter to you in terms of finding a job downstream? Healthcare is where a lot is spent, about $1 in $5. And as you can see by the bars, the year-over-year spend keeps going up. We had a little bit of a kick up in terms of the percentage of gross domestic product going to healthcare. That's mostly because during COVID, what we had is healthcare spending continuing to go up, but the rest of the economy contracting a little bit. So I think as we rebound from the pandemic, we'll see the GDP total spend of healthcare go down a little bit, but the total spend of healthcare overall is going to continue on that upward trajectory. And then 20.5 million jobs, healthcare focused, a lot of other jobs supporting people in that field. So the business of healthcare, the practice of healthcare is a high volume data environment. Literally everything that's done in healthcare involves data, starting with the payment of claims. Every claim for a medical service, for prescription drug, for durable medical equipment, that's DME, involves a data transaction between that provider and a payer. That payer may be a private health insurance company. It may be the government. It could be the state government in the case of the Medicaid program. It could be the federal government in the case of Medicare. And those claims have all sorts of different data elements to it. Starting with procedures, there's a current procedural terminology or CPT coding system that goes into claims. And then what are the records around that? Why is that person taking that drug? Why are they receiving that service? So physician notes, all the things in the medical record. Any lab work that you have done. So you have analysis, you have blood work done, you have radiology and X-ray and MRI. That's all data that can be mined. More and more, we're seeing the use of phone and email and texting, particularly as we got into the COVID pandemic. A lot of different ways of interacting between providers and their patients that weren't the norm before. I don't think that's going to go away. And then wearables, apps, a lot of survey research done, particularly in terms of satisfaction with care. It's all data points. It all gets databased. It all gets leveraged. At the end of the day, 80 megs per patient per year on average. I've also seen estimates that I have listed here that 30% of all data ultimately tracks back to the healthcare system in one way or another. Okay, so the big companies that are, and how they're data focused and healthcare focused. ExxonMobil, not so much in healthcare. They do provide health benefits to their employees. They're what's called a self-insured group, meaning they're taking on the risk. They contract out how that's managed to Aetna. So even they are in a part involved in healthcare. But then the rest of this list, they're all in one way or another in healthcare. Walmart, every major Walmart has a pharmacy. Walmart's now getting into primary care clinics. So they're all in healthcare. Amazon's got a mail order pharmacy. AWS Cloud is the cloud choice for a lot of healthcare organizations. Amazon's also trying to start up their own primary care clinics that they're going to use for their own employees, but also sell to other employer groups. And they are going to try to be telehealth focused. So that virtual work is going to drive a lot more data. Alphabet, the parent organization of Google, or to Amazon in terms of their healthcare portfolio, mostly focused on their cloud activities. Berkshire Hathaway, it's an investment company, invests in a lot of healthcare. Our friends at Apple, they're driving the wearables and the apps on the phone, also in the healthcare environment. Then the all-in companies. So I'm an alum of CVS Health. Most of you are probably familiar with them from a pharmacy perspective. They have roughly 9,900 pharmacies if you count the ones they run in Target around the country. But they do a whole bunch of other stuff. They are now the owners of Aetna, the large insurance company. They're also one of the top 3 pharmacy benefit managers, along with Optum and Express Scripts. And then they also, and I participated in this acquisition, they do what's called long-term care pharmacy. They bought a company called Omnicare, and that's the pharmacy provider of choice for skilled nursing facilities and assisted living facilities. So bringing the pharmacy to the patient. United Health Group, it's a mammoth vertically integrated healthcare company. They're also very much a data-focused company through their subsidiary Optum. They're providing data analytic and data science work for several major hospitals across the country and even some of their health insurance competitors. And then McKesson and AmerisourceBergen, they're both drug distributors, prescription drug distributors. And then they also do something called Pharmacy Administrative Service Organization. So they help independent pharmacies stay in business and provide some of the back end work for those pharmacies, including their IT and analytic work. Okay, some of you are saying, I don't want to work in healthcare. I want to focus on the tech data industry. But as you see here, those companies too are playing in healthcare. Microsoft Azure is the cloud provider for a lot of legacy healthcare organizations. Salesforce is used for sales and marketing, their platform. They're also now the owners of Tableau, that's used quite a bit in the hospital industry as a business intelligence tool. Uber got into healthcare because they realized that we have a problem where a lot of Americans either don't own a car or because of a disability or other issue can't drive, but they need to get to see their doctor. They need to get to the pharmacy and pick up their prescription drugs. Uber created an Uber health arm that does what's called non-emergency medical transportation. So you haven't had a heart attack, you didn't get in a car accident, you don't need an actual ambulance, but you need help getting to that provider or pharmacy, and you need it in a way that is more healthcare oriented and focused than what Uber would normally provide. By the way, Lyft also does the same thing, Uber's major competitor. Oracle, the database company, been around forever, has a version and a sequel. Oracle has been the database provider of choice for a lot of legacy healthcare organizations. More recently, Oracle acquired Cerner, and Cerner's the #2 electronic medical record company. So they're going all into that environment. And then I just used Amgen as an example, but every biotech company, every company that is making prescription drugs or other med tech equipment is very much data focused. So some of you may be saying, hey, that's great. A lot of those companies, they're not headquartered here in Western New York. I'd like to stay local. What about that in healthcare? And as you can see here in the Buffalo Niagara region, many of the top ranked companies in terms of employees are involved in healthcare. Obviously, Kaleida and Catholic Health from a hospital health system perspective. Wegmans and Tops are both pharmacies. They also sell over-the-counter medication and equipment. We already talked about Roswell Park, and then rounding out with Blue Cross Blue Shield of Western New York, which recently joined up with Horizon Blue Cross Blue Shield from the Pittsburgh area. And somehow this slide's missing a piece, but I'll talk this through anyway. So, all right, what about data-focused companies? Unfortunately, the list is missing from this. I'm not sure why, but of the, yeah, it might be. No, all right. Anyway, of the 50 top data startups from a venture capital perspective, these are all companies that are unicorn, meaning they're a $1 billion valuation or close to it. Virtually all of them either already have a healthcare arm or product, or they're looking to get into it. That doesn't mean that's going to be all that company's going to do. But again, as I started off with how much of the economy is based in healthcare, it's hard to scale a business and not think about playing in that environment. So just wanted to talk about what's the analytics box in a typical healthcare organization today. I underscore current because this is a rapidly changing environment. Talk through some of these tools and what are the sort of back and forths there. Most analysts, scientists traditionally have been using SQL to pull data out of databases and then doing analytics in one of the top 3 legacy old school programs. And I talk about how that's kind of shifting a little bit. SAS data and SPSS. Now, SPSS not being used so much, kind of going away, really more of a focus of survey researchers. So if you're in a large healthcare organization, your sales and marketing team may still use SPSS. People doing work with surveys in the healthcare field, there's a survey called TAPS. A lot of those folks may still use SPSS. You're not going to really see other departments using it. Stata, however you want to pronounce it. Really only healthcare economists use this at this stage. Really common in the academic environment in the old days. Today, you see healthcare economists still use it. Most of them are employed in actuarial firms or in other sorts of consultancies. SAS, however, has its claws deep in the healthcare industry. They've been able to inject themselves into contracting and other things that even if the folks doing the work would rather use other tools, it's there for a while, particularly amongst health services researchers and folks working in the government. Then on to business intelligence. Early on, Tableau kind of got the lead in terms of doing BI work and visualizations in the healthcare space. A lot of people like using it. Microsoft picked up on that. And what Microsoft tends to do is they go and talk to your CEO and they talk to your CIO. They talk to the C-suite people about other business-to-business services. So Azure, other things that Microsoft does. And then when they sell the company on that, they also tell that C-suite individual, hey, by the way, you ought to use our BI product. So I was actually at a company where everybody was using Tableau, and all of a sudden we moved to Microsoft Azure for cloud services. And they talked the CEO into, dump that Tableau thing and do Microsoft Power BI. I've used both. They both have great capabilities in different ways, but I use that example as something you may see throughout your career is sometimes you get required to use a tool, not because it's the best tool or because it's the tool you want to use or your colleagues want to use that are actually doing the work. It's because somebody higher up the food chain's made that call. So that brings us to Excel. Excel's never going to die. And here's why. We may not like Excel for certain things. I actually do like it for a handful of things. But the bottom line is this. You don't exist in an organization if you don't have a budget. Who controls the budget? The finance department. What do finance people do? They do Excel. So your CFO, all the people in that line, they're going to be Excel jockeys and they like Excel, and they may do other things too, but they like Excel. And then from some perspectives, it's also, again, evil Microsoft. So if your company's using it, any Microsoft product, they're going to be pumping you to use Excel. Lot more work now in geographic information systems. The granddaddy product for that is ArcGIS. A lot of large organizations sign multi-year deals to use that product. I don't know where that's going to go long term. I see a lot more people doing mapping work in Python, for example. So we'll see where ArcGIS lands in the long term. Simple heat maps too, see that a lot of that in Power BI and Tableau. And then Looker is an up and comer from the Google perspective. So I see that more in startups and smaller organizations in healthcare that like using Google products. And so they're using Looker. Python and R, a lot of folks like that, a lot of capabilities, a lot of flexibility. Here's what I'll tell you about them in large organizations. It makes chief information officers, particularly the security officer, panic about open source and whether it's secure or not. So a lot of times, if you like using Python and R and you're in a large organization, you may have to promote them. You may have to talk to executives about why that's a good direction to go in. Oddly enough, SAS and SPSS and some of the other old school programs are also starting to build out capabilities to leverage Python and R. So I think Python and R aren't going anywhere. Their use is going to grow. But if you're in a large legacy organization that's kind of conservative, you might have to be talking to some folks about where to go with that. So some of the common analytic use cases in healthcare, there's a lot of different ones. I just picked 3 random ones, really. Lot of work in healthcare right now on, hey, if we're spending all this money, we just talked about, CMS alone spending 1.4 trillion. We talk about $1 in $5. We better be getting something for it. So there's literally hundreds of quality metrics that are being developed in healthcare, mostly leveraging that claims data I talked about. One of them is, hey, if you go to the hospital and you got quality care there, we shouldn't see you again for the same condition, unless if there's a really good reason for that. So most hospitals have a hospital readmission measure that they're being gauged on by payers, and their payment gets reduced if they don't hit certain targets in that measure. Clinical trials. Nothing happens in the prescription drug space unless if there's been as controlled trials, very traditional research environment, a lot of that work being done in academic medical centers by traditional MDs and PhDs. Are they going to leverage data science folks for that? Sometimes. Where data science comes more into this field is after that drug is approved by the Food and Drug Administration. The Food and Drug Administration may require, or the drug manufacturer may, for marketing and other purposes, decide to do what's called post-marketing surveillance. And that's where they're leveraging big data, real world. Because if you've ever learned about clinical trials are the farthest away from the real world. They're trying to control every scenario to remove confounds, but also to drive the result they want. So when somebody's trying a drug in a clinical trial, they're getting care that nobody else gets other than maybe the president of the United States. Everybody is all over them, making sure everything's going well at every step. But that's not the real world, right? In the real world, you get prescribed a drug. Maybe you couldn't make it to CVS or Rite Aid that day. So now all of a sudden you're taking that drug, but you're taking that drug a week later and your doctor told you to do. Maybe you can't afford the copay. So it's important to then look at real world data and see how this plays out once you get outside of that clinical trial environment. And then I talked about patient member satisfaction. Business guys like to talk about promoter score. I'm not going to get in the weeds on that, but this is in healthcare, this tends to be pretty old school. There's actual paper surveys still being used. Those paper surveys sometimes are converted into a phone environment. I think that's going to change. There's already actually a proposed rule at CMS in the Medicare space where we're going to see surveys done this way, as it should. But it's generating a lot of data about how people feel about the care processes they're engaging in. The hospital they went to, the doctor, or the pharmacy they picked up their prescription drugs from. Or in the case of a health plan, whether they like dealing with that health plan, the enrollment process. With a prior authorization, how did that go? They called up customer service. How did that go? That all goes into both a business process improvement perspective, but also the government and other payers tend to adjust payment by how you perform in these surveys. Then I wanted to give a sort of more drilled down use case. So this is a real problem that existed several years ago in the insurance industry. And so what we have is a stripped down version of this. And we've got one person who's very healthy and on average costs $100 a month. We've got a person that's a little bit older, has minor depression. They're costing $500 a month. And then we've got a third person that's older, has hypertension, type 2 diabetes, and costs $900 a month. And the ultimate payer, the government or an employer, is willing to pay the insurer $500 per member per month to take care of this population. So you're an insurance executive. Do we want to enroll person C if we're getting paid $500 a month? No. How about person B? We'll break even. Is that okay? Or do we want to try to avoid person B? We're wanting to enroll person A because then we're making a $400 profit a month, right? This is called selection. And this was a real problem that existed where I worked for an insurer years ago. And when they did enrollments, one of the ways that they did selection for enrollments is we're always the second or higher floor of a building that did not have an elevator. If you could make it upstairs, you were healthier, right? And there were all sorts of schemes like that used to go on. Big. So how did data scientists, they weren't necessarily called that then, but they were, how did they solve for that? In the Medicare situation, what data scientists did at Medicare is they realized, okay, Medicare is sitting on gobs and gobs of data. Millions of Americans are enrolled in Medicare. We're collecting data on them every year. We've got data longitudinally for decades. What do we have? How can we develop a risk adjustment model to change how plans are paid so they won't try to purposefully select person A? And I got to be involved in the development of the risk model for the Medicare Advantage program, which is a voluntary program. If you're a Medicare beneficiary, you can stay with government-run Medicare, or you can join a Medicare Advantage health plan. And right now, it's about a 50-50 split. Back then, it wasn't. And then we also developed the risk model for the prescription drug program in Medicare using the same set of data. Age, gender, whether the individual is impoverished, in this case measured by whether they're in the Medicaid program or get the low income subsidy in Part D, whether they aged in 65 and up or got into Medicare because they got there because of disability status, whether they lived in the community or were in an institution like a skilled nursing facility, and then all their medical diagnoses. Right-hand side, I wanted to point out some of the things that if we had the data, we would have used. We didn't have the data. So this is a lesson in sometimes the technical solution mathematically or the technical solution from a theoretical perspective, we may all agree exists, but if you don't actually have the data or the ability to acquire it, you got to use what you got. And that's what happened here with the risk adjustment models. We had to use the data that existed. So those models were developed back in 2004, 2005, and they're still in use today in a multi-billion-dollar program. So having done this for over 2 decades, graduating from being an entry-level data analyst to being an executive in the insurance industry, being a senior leader in Medicare, I wanted to impart some observations and insights from that career on you as you guys move forward. First, this is what my first data analyst job looked like. I had to, so we had a IBM mainframe. It was coded in an ancient language called COBOL. You teach anybody about COBOL anymore? By the way, there's a lot of work to be had in systems that were coded in COBOL. People get grossly overpaid for that, so that's a good opportunity. But so our desktop computers in the entire organization I worked in, it was called Coordinate Care. It was a nonprofit that worked with Erie County Department of Social Services running the Medicaid program. And so our desktop computers were not networked to this IBM mainframe. So what I had to do is write up business requirements in a memo, and I had to walk it to the IT department, and they would pull the data according to my requirements, and they'd put them on those floppy disks. And that's how I got data in my desktop. I also got data from the federal government on CD-ROMs, like this one from the Centers for Disease Control, all on a Windows 95 machine that had 2 tools on it: Excel, SPSS version 6.1, one of the first in the Windows environment. And back then, the web browser of choice was Netscape. So the net takeaway from this is, it's great you're here, you're learning a lot in this program. Never stop. Doesn't mean that you need to get a PhD. It doesn't mean that you need to get 5 more master's degrees, but keep learning. The world's going to keep changing. There's going to be new tools. There's going to be new data. There's going to be new technology, new problems to solve for. And the only way you're going to be able to navigate that world and do the things you want to do is by keep learning. That is a team sport. In academia, when you're going through school, you're tested individually, you're attending as an individual. Once you're in any organization, you're working in a collaborative environment. And I talked about before, you can't do anything if you don't have a budget. Part of that collaboration is getting budget for the projects that you want. Being able to acquire the data that you need, being able to use the tools that you want to use. If you're in a large organization, you're going to engage with engineers. You're going to engage with executives. It's a team sport. Data security, particularly in the world that I'm in, big deal. When I started off, there was not a lot of hacking in healthcare. Hacking was more focused on people going straight at businesses, trying to steal credit cards, going after banks, etc. Over the years, that's migrated to where there's regularly hacks in the healthcare environment. So anybody working with data wherever you are, but particularly in healthcare, because of the sensitivity of the information, be minded. That can get in the way of the analytic work you want to do sometimes, but you got to do the right thing. I'm not going to read this quote, but critical thinking is really the most important thing there is. And I liked how Suresh said here, it's even more important than statistics or machine learning or AI. At the end of the day, you're being hired to solve problems. Your tool of choice is data science, data analytics, statistics. But at the end of the day, you're solving problems, and that requires critical thinking. It goes back to my other point too about lifelong learning. If you're a critical thinker, you may realize, hey, this tool I used in the last project, not the right one for this one. Maybe I need to learn something else. Maybe I need to learn more about the data I'm working with itself. Navigating the job market. We've done a lot of hiring. In fact, going all the way back to here, I was involved in hiring Muriel Howard when she was president of the school. And throughout the years of being a supervisor, being upper management, being executive, a lot of hiring of different people for different things. What I've observed is often hiring processes are botched. The HR people involved, others, particularly senior execs, don't really know what they're hiring for. And so what I picked here is these are real world examples. The left one comes from a hospital. The right one comes from a consulting firm in the DC area that works with the Food and Drug Administration. And both of these were listed as entry level, but I want to note a couple of things that, from my perspective, where they went wrong on this. And I think you're going to likely see this as you're looking out in the job market. First one, this is entry level, but it's saying minimum of 2 years experience, but it's not defining what that experience is, right? It's not entry level if they're requiring 2 years of full-time work experience. So that's a red flag. The IE instead of an EG. So IE tells me they're using Power BI and they want you to use Power BI. Okay, maybe that's right. Maybe that's not. Experience communicating insights to senior stakeholders. Frankly, that's not, unless if you're working in a really small organization, small nonprofit, startup. Most of you, if you go in a larger organization, you're not going to get to brief the CEO on day one. Okay. Not a problem. That's not a reflection of your skills or your abilities, but why is that in an entry level job? And in this case, we're not talking about a small organization. This came from a very large hospital health system. Serving as a subject matter expert. You all want to be a subject matter expert eventually. You're going to develop into subject matter expert. You have subject matter expertise. You're going to be a subject matter expert in an organization you've never worked in. So again, how is this entry level? Okay. So with all that said, and we have similar criticisms of the other one. What do you do if you see a posting like this? You want the job. You like the organization, you like the role, it's data that's interesting to you, you want it. Apply anyway. When you interview, particularly on the early stages, explain what you can do for that organization, how excited you are about that organization, how you've looked into that organization, what they do. And then if they ask, well, hey, in our posting, we said Power BI, and I'm looking at your resume, you've never done Power BI. Be able to explain how you can learn Power BI. or whatever that tool may be, or whatever that skill that's listed that you don't necessarily have right now. Talk about your learning process. Talk about how you didn't come in the door knowing Python here, but you learned it. Because chances are everybody else applying for this too doesn't have a check for each one of the things on that posting. If you can go in with a positive mentality of like, this is what I bring already, this is how I bring value, you're likely to get that job. Domain expertise, knowing your data. So in one of my roles when I was an executive, we were having a meeting. Suite was involved, other executives, and the lead presenter that day was a data scientist, had a PhD in biostats, really brilliant person, and he botched the presentation. He outright embarrassed himself. Why? Because he didn't understand the data he was analyzing. The C-suite actually asked me to fix the project. And when I sat down, I looked at his SQL code, nothing technically wrong with it. The stats he picked were done beautifully, all accurate. The problem is he was pulling data from only a subset of the population. The reason being, he didn't understand what that data was. I can get in the weeds about it. It's a program thing in Medicaid, but he didn't bother asking. He didn't bring anybody into his team that was an expert in that program. Often I've seen other data projects blow up in a similar way to this. In healthcare, obviously, you'll have a nurse or a doctor or a pharmacist, depending on your project, on your data team. Anybody here have an MD along with what they've done here? How about a pharmacy doctorate? No. That's why. If you're working in healthcare and you're doing something heavy medical, you kind of got to have somebody there to explain to you what the data is that you're working with. What I also put in here is Google research actually, in a self-critical way, analyzed all their major project failings. And when they did that, there were other reasons, but one of the top reasons for a project failing, after doing analysis of why, in 43.4% of those cases, it was the team didn't even understand the data that they were using. So no domain expertise. You may be able to achieve your own domain expertise. So don't think that you always have to go outside and bring in other experts. But don't know something and either learn that or bring in those outside experts as part of your team so that you're not making those same mistakes. And that's it. Q&A, right?
Perfect, yes.
Thank you.
I'm seeing a big divide there's older people that don't like technology. So we have a lot of apps as well. We do all our coding with apps, right? It's efficient. You can collect the data. However, a significant amount of people that just don't use smartphones, don't want to use a computer. How long do you think it's going to take? How many years to get a generation that's comfortable with technology to feel comfortable doing it with apps to collect that data?
So I've observed a couple of things there. One, older folks, and my grandmother is an example, I think, that are very comfortable, but not for healthcare. They view this is for fun. This is Facebook. This is, I look up things I like and watch YouTube videos on cats. But I don't do serious stuff on this. So I think that's a barrier there. There's no single straightforward answer. It's an evolution. I think over time, as more and more work is done on apps, and in the healthcare field too is how we're using FHIR-based APIs a lot more. I think that we're going to see more and more of it, but people have to get accustomed to that. This is secure. I can trust it. So back to my security points, I can be confident in that, and that it's an appropriate way of doing things. That healthcare is not just about I go into my doctor's office and talk to him or her in behind those closed doors. So it's going to take time, and it's not. While that's more of a challenge with the Medicare beneficiary population, I've experienced that across the board. That people are still a little bit leery about doing things on a phone that are involving their care.
Have you ever ran into any big instances in failure of data quality in healthcare, and how did you manage?
Data quality is a huge issue, and one not just in healthcare, but definitely in healthcare. Data quality is a huge issue, and one that needs more work. For one, there are financial incentives where different organizations may actually be outright engaging in fraud to get paid. So there's a lot of data work actually in fraud detection and prevention. Then there are people that don't want to be accurate about a problem they have. So we see a lot of issues around data quality in the mental health space, behavioral health space, where people don't want to admit the problems they're dealing with. And then data quality, I'd say an adjacent issue to that is just that we're not collecting the right data for the problem we're trying to solve, and then we force it. So the underlying data may be reliable, it may even be valid, but it doesn't actually answer what we're trying to answer. You see a lot of that of where problems are trying to be oversimplified as only being about sociodemographics. Sociodemographics are always important, but let's say it's an issue that's more genetic or a much more complex issue. You've got to collect a lot more data to really be able to answer the question. Even that risk adjustment model I talked about earlier, anyone want to guess what the R squared on that model was? It was less than 0.2. And yet it's being used for payment of billions and billions of dollars. Yeah. Not uncommon, because again, like, you can theoretically think about all sorts of ways of getting your predictive validity up in a model, but do you actually have the data at scale to use? So in an academic environment, we're often able to do things that in the real world can't do. In a research environment, you may be able to do. You get a grant, you get other support to do things, but you got to make do with what you have in the rest of the world. So
I might have seen it, but in one of your slides, the analytical use case, there was something about a readmission metric that the hospitals have. I guess my question is do you find in the data, I don't know if this is possible, like either health professionals discouraging people from coming back, or the hospitals like kind of misreporting the data? And this kind of goes into the last question, just to try to lower their remission rate score.
And the answer is yes, that happens. So that's a great life and career use case in of itself. Understand that your data solution may create new problems. So being able to project forward of like, how could this be misused, and what are financial incentives out there, and then how can I mitigate that risk? So I talked about before fraud prevention. what you're describing at its worst would be a case of fraud. So there's analytic capabilities that can be brought to bear to do fraud prevention. So yeah, that's an excellent example of we solve one problem, it potentially creates another. So we have to, again, be critical thinkers. What are our tools and data to solve for that downstream problem?
What steps should a DSA student take to put themselves in a position to obtain working under you at a competitive salary?
We'll graduate from this program. You know, I think the internship opportunities are pretty critical from a start off. Then I would recommend, you know, field or organization you're interested in and live it. That's how you're going to learn the data and be part of that whole profession around it. So one of the things that I'm doing now on a volunteer basis is working with the American Health Information Management Association. And what that organization is a collection of data analysts and scientists in the healthcare field, and then people that are involved in the collection of raw data on the ground. So medical coders that are sitting down and reading medical records or working along with scribes and others with doctors to document a care encounter. And one of the challenges on the analytics side for a lot of that data is it's a lot of open text field. Yeah, we have natural language processing, but it's not always that great yet. And a lot of things aren't standardized. So AHIMA as a standards organization is working to get data collection standardized a lot more in the healthcare field. And you can get certified with them and learn a lot from. That's just one example. There's literally dozens or more in healthcare professional organizations that you can work with and learn and sit down with other experts and learn from them. And if you do that, you're going to get paid well.
How do you recommend switching industries from finance to healthcare?
I mean, healthcare is full of finance, so that's one pathway of getting into it. I talked earlier about all the different ways in which a finance department's engaged. And then, you know, every organization out there, whether it's a startup looking for venture capital, dealing with finance people, an organization that's already started up trying to scale, they're doing an initial public offering, they're going to the street, finance people are involved. Every healthcare organization has to do basic accounting. So that's one pathway from that angle. You've got my contact information, contact me, we can talk more about it. And that goes to all of you. If you're interested in this field or just want to hear my thoughts on anything, you know, reach out to me.